and it is a true honor to co-chair this session together with Professor Henrika Boetsma, Professor of Rheumatology at the University of Groningen and one of the most respected leaders in the Sjogren's field worldwide. Henrika, a real pleasure to share this with you.
Thank you.
Well, the objectives of our session today are to recognize the severe extraglandular manifestations of Sjogren's disease, to discuss representative complex cases in depth, and to provide the latest advances on tailored therapeutic approaches. We will work through 2 complex clinical cases, each with 10 minutes of case presentation, followed by 20 minutes of expert discussion, closing with questions and answers. We kindly ask all the speakers to be strict with the time.
We will start with the case concerning Sjogren's patients and associated malt lymphoma. And this case will be presented by Lucas Sacchi. He's an academic fellow at the Department of Pathophysiology at the University of Athens and a member of the Research Institute for Systemic Autoimmune Diseases. And he's one of the emerging voices in Sjogren's disease research. And his research is focused on B-cell biology. So first we will listen to his introduction. The floor is yours.
Thank you. Thank you for this very kind introduction. So today my role is to walk you through the clinical cause, the histopathological evolution, and the final outcome of a patient presenting with recurrent parotid gland enlargement from our Sjogren's disease clinic back in Athens, before I give the floor to Professor Andreas Goules to discuss about the complex intricacies and the challenging relationship between Sjogren's disease and lymphoma. I have no conflicts related to this case presentation. So our patient is a female presented in 2009 with bilateral parotid gland enlargement, more pronounced on the right side. Salivary gland ultrasonography raised suspicion of Sjogren's disease, but our patient decided not to pursue any further investigations at that time. For a couple of years, he was fine, but after salivary gland enlargement, parotid enlargement on the right side reappeared. This time, it spontaneously resolved within a matter of days. But a year later, she experienced the 3rd episode of salivary gland enlargement, parotid gland enlargement, this time accompanied by clinically evident Zika manifestations, dryness in the mouth and eyes. At this time, a full diagnostic workup revealed Sjogren's disease diagnosis with a compatible minor salivary gland biopsy with a focus score of around 3, anti-Rho SSA52 positivity, anti-La, rheumatoid factor and cryoglobulins were negative, and positive objective dryness tests. The minor salivary gland had no germinal centers or lymphoepithelial lesions at that time. There was no clonality detected either on immunohistochemical or molecular studies, and of course there was no lymphoma. Over the following years, our patient continued to exhibit features suggestive of chronic B-cell activation. In 2020, she developed cervical lymphadenopathy. A lymph node was obtained, and it has features suggestive of autoimmune lymphadenopathy with a follicular lymphoid hyperplasia, with a rich dendritic cell network associated with a high CD23 positivity. However, the nodal architecture was preserved. At this time, we repeated the minor salivary gland biopsy that prima facie had similar findings, a focus score of around 2.5. Just recall that it was 3 before. However, this time, there was germinal centers present, there was monoclonality at the molecular level, and there were some pre-lymphoid lesions. You can find some lymph nodes across the salivary gland epithelium. Between 2020 In 2025, our patient demonstrated yearly episodes of parotid gland enlargement. Our team suggested biological treatment with anti-CD20. However, our patient refused due to concerns of complications. Things changed in May of 2025 when she developed once more parotid gland enlargement on the right side. However, this time, the parotid gland enlargement did not resolve. And this incomplete resolve, even after methylprednisolone treatment, demonstrated a severe clinical warning sign and prompted us to do another biopsy on the right parotid. And this time there was a dense lymphoplasmacytic infiltration that really breached the salivary gland epithelium, resulting in loss of ductal lumen. This is lymphoepithelial lesion stage 3. However, the material was not enough to substantiate multiple lymphoma diagnosis. However, the patient continued to deteriorate, and a few months later, she contacted us, complaining of profound fatigue. And this urged our team to suggest an urgent hospital evaluation. The medical history was positive for 2 autoimmune diseases, Sjogren's disease diagnosed in 2012 and Hashimoto thyroiditis that is known for decades, and also one oncologic disease. She had left breast adenocarcinoma that was resected and was considered fully treated. She was on hydroxychloroquine for from the day of Sjogren's disease diagnosis and no other immunomodulatory or immunosuppressive treatment. On admission, the patient did not appear very well. She had cervical lymphadenopathy, measuring approximately 2 to 3 centimeters, that was enlarged from the last visit. It was also present in the right supraclavicular lesion that was not present before. There was bilateral parotid gland enlargement, more prominent on the right side and more prominent than ever. She had anasarca, jaundice, and a palpable and firm liver. Laboratory investigators demonstrated severe systemic inflammation and organ dysfunction. The patient was anemic, thrombocytopenic. There was nothing at this in the previous visit. The patient had a markedly increased liver enzyme elevation, high bilirubin, and raised CRP and ESR levels. During hospitalization, as expected, further diagnostic procedures were performed. A bone marrow biopsy and a right cervical lymph node biopsy were immediately obtained. However, and unfortunately, the patient deteriorated due to a SARS-CoV-2 infection, and despite our best efforts, clinical improvement was not achieved. The patient was intubated, and she was transferred in the ICU, and a day later, she died because of a respiratory tract infection complicated by septic shock. The final pathology was compatible with a CD10 negative, CD5 negative DLBCL from the Germinal Center, as was compatible in the lymph node biopsy, which was induced by medium to large CD20 positive B cells that are also positive for BCL6, also positive for BCL2 and MYC. This is a triple hit DLBCL lymphoma with a high Ki67, more than 70%. Notable is the fact that in some areas of the same lymph node, there was very low proliferation index, almost 5 to 10%, suggesting that this is probably an aggressive transformation of a multiple lymphoma to a DLBCL. That was also found in the bone marrow. So to sum up and wrap up the case, we had a patient that 15 years ago had some aggregates, extensive aggregates of B and T cells, that over the years were organized into structures, this is called germinal centers, with some clones prevailing and also having the ability to invade some pre-lymphoepithelial lesions. Over the following 5 years, these B cells became more invasive and completely destroyed the epithelium. This is a stage 3 lymphoepithelial lesion. Somewhere and at some point across this timeline, probably in the right parotid or somewhere else, multiple lymphoma had been developed that ultimately gave rise and gave birth to a DLBCL, aggressive lymphoma, that was related to the devastating outcome of our patient. And I think this is a case illustration of a patient with Sjogren's, showing the evolution, the biological and clinical evolution of lymphomagenesis in the disease. And with that, I will give a pass and assist to Andreas Goules to continue talking about bottom-up from the specific to more generally about Sjogren's disease and associated lymphoma. Thank you so much.
Thank you very much, Lucas, for the excellent case presentation. And for the expert discussion, I'm delighted to introduce Dr. Andreas Goules. He's professor at the Joint Academic Rheumatology Program, Department of Pathophysiology, also at the University of Athens. And you did a lot of work on lymphoma during the last several years. So it's nice to introduce you.
Thank you, Henrika. I would like to thank the organizing and scientific committee for the invitation, the professors Bootsma and Brito Zeron, who are chairing this session, my co-speakers, especially Professor Giacomelli, and all of you who attend. So, Lucas gave us the opportunity to discuss a little bit about Sjogren's disease-associated lymphomas. These are my disclosures. First, I will start with some clinical features of Sjogren's disease-associated lymphomas. Then I will present some data for multiple lymphoma predictors, and I will finish with a few words about multiple lymphomagenesis and treatment modalities. So I think it's more than clear that Sjogren's disease carries the highest lymphoma risk among all systemic autoimmune diseases. This is well documented in the literature, and that the associated lymphomas have a significant impact on mortality and morbidity of Sjogren's disease patients. Mainly, there are two main histologic types of lymphomas, the mucosa-associated lymphoid tissue lymphomas or multiple lymphomas, and the DLBCL lymphomas, diffuse large B-cell lymphomas. The first type account for 65 to 70% of cases, and the second 10 to 15%. Now, these two histologic types have many differences in terms of clinical presentation, prognosis, and treatment. So multiple lymphomas are almost always present with extranodal involvement, meaning in clinical practice with parotid or minor salivary gland swelling. A few patients may also present with lacrimal involvement. The multiple lymphomas carry also a systemic component, clinically expressed as cryoglobulinemic vasculitis, and a small proportion of patients may develop constitutional or B symptoms less than 20-25%, and a small proportion may also present with lymphadenopathy involving mainly the cervical and axillary lymph nodes. So keep in mind that multiple lymphomas, they present as swelling of parotids or minor salivary glands. On the contrary, DLBC lymphomas are usually present with nodal involvement, cervical, axillary, and sometimes mediastinal. But in a significant proportion of patients, they may also involve extranodal sites, and especially the salivary glands, sharing common clinical manifestations with multiple lymphomas, and they have a strong systemic component, again sharing the cryoglobulinemic vasculitis with multiple lymphomas, and in a significant proportion of patients, more than 50%, DLBC lymphomas may present with constitutional symptoms. Common features with multiple lymphomas, and we know from the literature that in some cases DLBC lymphomas may develop upon pre-existing multiple lymphomas. There are some alarm signs the clinicians should be aware of to suspect an underlying lymphoproliferative disorder in the context of Sjogren's disease. You can see these alarm signs. Some of them suggest clearly multiple lymphomas, some others DLBC lymphomas, but in some cases you must suspect both persistent salivary gland swelling, generalized lymphadenopathy, constitutional symptoms, new onset cryoglobulinemic vasculitis, new onset monoclonal serum component, and hypoglobulinemia, which was not present in the past. we should be cautious. In some cases, patients may present with rapidly progressive dyspnea with strong ILD component. In these cases, we should suspect an underlying bulk lymphoma, bronchus-associated lymphoid tissue lymphoma. In the context of these specific alarm signs, we need to rule out the existence of lymphoma. Typical and classical blood exams, patients should perform CT scan of the neck, chest, and abdomen, and if necessary, PET-CT. The key point is to perform biopsy of all involved sites. In patients with hematologic abnormalities, it is necessary to perform bone marrow biopsy. And in these cases, in our center, we also perform gastroscopy and ultrasound of the thyroid gland to document a second site. This is not a validated strategy. It is what we do in our center. Now, the two histologic types have also differences regarding prognosis. In the left graph, you can see the 10-year overall survival rates, 40% for DLBC lymphomas and 80% for multiple lymphomas. Multiple lymphomas are not so innocent as we thought in the past. This means in clinical practice that 20% of patients with multiple lymphomas are expected to die 10 years after the diagnosis of multiple lymphomas. And in the right graph, you can see the event-free survival rates. They're very low for both histologic types. Both types evolve adversely. And of course, the DLBC lymphomas are worse, but still multiple lymphomas, in half of patients, they progress, meaning patients relapse, or there is histologic transformation, which is well documented in the literature. This is the multi-PI score, which was revised in 2022. And you can clearly see that this is a scoring system to assess prognosis in patients with multiple lymphomas. And the stage, the famous Ann Arbor stage, if it is advanced, this is associated with worse prognosis. And in our cohort, we found that 20% of patients with multiple lymphomas have already bone marrow involvement, and they are classified in an advanced Ann Arbor stage. So multiple lymphomas are not so innocent. Very soon, they may involve bone marrow, and there is a deep need for early diagnosis, not only for DLBCLs, which are not so common, but for multiple lymphomas. Many groups in the past 30 years have proposed lymphoma predictors for early diagnosis and follow-up of patients. And actually, these predictors reflect prediction of multiple lymphomas because this is the main type: salivary gland enlargement, cryoglobulinemia, hypocomplementemia, rheumatoid factor, and high focus scoring lead biopsies. These are traditional, let's say, predictors of lymphoma in Sjogren's. But in all these studies, there are some limitations. First of all, the typical logistic regression models were employed. And there's an issue with the time distance between Sjogren's disease diagnosis and lymphoma diagnosis. In all these studies, this time distance was 1 year. At this point, it is important to emphasize that the disease itself and multiple lymphomas share many common clinical manifestations, especially cryoglobulinemic manifestations. And if there is a tight temporal clustering between Sjogren's disease diagnosis and lymphoma diagnosis, some manifestations may be falsely attributed to the disease itself instead of the underlying slowly progressive lymphoma. To overcome these obstacles, we conducted a study employing data-driven the FCBF logistic regression analysis, analyzing data from 80 patients whose lymphoma diagnosis was at least 3 years apart from Sjogren's disease diagnosis. And this is the time point of Sjogren's disease diagnosis, the V1 time point. And you can see that rheumatoid factor is the only independent multiple lymphoma predictor at the time of Sjogren's disease diagnosis. And in the second time point, V2, 4 years after Sjogren's disease diagnosis and before lymphoma diagnosis, another second independent factor appeared, the SSDI more than 5, increased systemic disease activity. And of course, the question is, which domains of the SSDI, which is a complex index, are responsible for this additional risk factor? And you can see the answer in this graph. Compared to patients with no lymphoma, those who are about to develop lymphoma present 4 years after Sjögren's disease diagnosis glandular manifestations, meaning salivary gland swelling, cutaneous manifestations, meaning palpable purpura, neutropenia, and of course, cryoglobulinemia. So patients who are high risk and are RF positive at Sjögren's disease diagnosis follow a specific clinical trajectory, and this is a roadmap to follow up patients. Another question is if there is room for repeated biopsies for early diagnosis of lymphoma in Sjögren's patients. We analyzed data from more than 600 lip biopsies in our center, and we found that the threshold of focus score 4 has clinical significance because over this threshold, the lymphoma risk increases, and there is a difference, a time difference in lymphoma diagnosis between the high focus score group over 4 and the low focus score group before 4, less than 4, and there are 9 and 4 years time to lymphoma diagnosis. This is statistically significant, and if you analyze the data, you will see that the low focus score group with focus score less than 4 have a significant risk factor for lymphoma, which is the history of salivary gland enlargement. So a second biopsy can be repeated in 9 years to catch up the diagnosis of lymphoma. For those with focus score more than 4, the time to lymphoma diagnosis is 4 years, is short, and the focus score itself is a risk factor. All of these patients who are not, of course, many in the Sjögren's disease population can repeat a second biopsy. Of course, these are data from one center, and this strategy needs validation, but offers the opportunity to start thinking about repeated lip biopsies as a tool for early diagnosis. Going back to our case, we have a lady who had recurrent and then persistent parotid gland enlargement and stable cervical lymphadenopathy. This is consistent with multiple lymphoma diagnosis. There's no cryoglobulinemia. She was RF negative. I would like to remind you that almost 30% of patients with multiple lymphomas are RF negative, and 60-70% are cryonegative. And always keep in mind that DLBC lymphomas may arise upon pre-existing multiple lymphomas. Histopathologically, in 2020, the patient had lymphoid hyperplasia in the lymph nodes, as Lucas stated. There was no evidence of multiple lymphoma or DLBC lymphoma in the lip biopsy, but she started developing ectopic lymphoid structures together with B-cell monoclonality and early lymphoepithelial lesions, and all these point out an ongoing B-cell activation. 5 years later, the biopsy of the parotids showed advanced lymphoepithelial lesions, B-cell monoclonality, and small lymphocytes consistent with the presence of multiple lymphoma. And in the cervical lymph nodes, it was documented the DLBC lymphoma, and some regions with different proliferative capacity within the cervical node, pointing out that you have 2 neoplastic populations within the cervical lymph node. And of course, bone marrow was also involved. Managing is not always treatment. It's sometimes difficult to set the diagnosis and follow up the patient. That's why we present this case. So we have a clinical and histologic suspicion of an underlying multiple lymphoma evolving in the context of a chronic B-cell activation, and upon this, a DLBC lymphoma developed with generalized lymphadenopathy and bone marrow infiltration. Apart from the difficulties in following up patients and set up the diagnosis, there are 2 important clinical questions in this case. First, could we do a third biopsy between 2020 and 2025 to have an early diagnosis. Of course, we don't have data to support this strategy, but it is an open question. How often do we have to do repeated biopsies, lip biopsies or parotid biopsies to follow up this type of patients? And another clinical question is if B-cell depletion therapy after 2020, that the B-cell ongoing activation has been documented, if this B-cell depletion intervention would change the course of patient. It's still an open question. I don't have an answer. We recommended the B-cell depletion therapy in the patient to control recurrent episodes of parotid enlargement. She denied, and there is no clear answer if such an intervention would change the course of this patient. A few words about the mold lymphomagenesis. It is tightly associated and linked with cryoglobulinemic vasculitis. We know that RF-positive B-cell clones at the initial stages of the disease are selected and expanded in an autoantigen-driven process through many different mechanisms. And these clones, as they expand, they acquire at the VDJ region mutations to obtain the cryoglobulin properties. And some of these clones, very early, they incorporate somatic mutations, and at the end, they cross the line towards malignancy. The opposite is also possible. 75% of Sjogren-associated multiple lymphomas, they develop RF positivity, and there are specific VDJ rearrangements at the BCR receptors, and not all of them, they have cryoglobulinic properties. And this is the mutational landscape of multiple lymphomas in salivary glands, data originated from two main studies, analyzing 71 samples, ended up with 19 genes which were found mutated at the level of salivary glands in patients with multiple lymphomas. And these genes are associated with specific biologic processes, NF-kappa B activation, B-cell differentiation, tissue homing, epigenetic reprogramming, and immune escape. The mutational landscape of multiple lymphomas associated with Sjogren is still dark. Treatment modalities. For multiple lymphomas, there are three options: wait-and-see policy, B-cell depletion. Now we have many different B-cell depleters, and combination treatment with B-cell depletion plus chemotherapy. There's no solid data. There's only the work from the French group showing that the combination treatment reduces the relapse rates of lymphoma, and the maintenance treatment with anti-CD20 also reduces the relapse rates for lymphomas, consistent with the famous MAINTAIN clinical trial. And for DLBC lymphomas, I think there is only one option, the famous R-CHOP regimen for this aggressive type of lymphoma. Concluding remarks. The associated lymphoma affect definitely mortality and morbidity of patients. And in the context of alarm signs, we should exclude the underlying lymphoproliferative process. The key point is to do biopsy in all involved sites, very careful samples, because there is a patchy nature of lymphomas, especially at the level of salivary glands. We know that for high-risk rheumatoid factor positive patients, there's a specific trajectory to follow up. Repeated biopsies is a matter of open question and needs validation. The combination therapy for the moment seems an appropriate treatment for multiple lymphomas, and of course there are many unmet needs. There are no predictors for DLBC lymphomas in Sjogren's. We are not sure if this is the proper treatment, and the timing to intervention is not clear, even for multiple lymphomas. There is an open question if early interventions, such as in this patient, in high-risk patients, will finally prevent the development of lymphoma. It is an unmet need. And in terms of pathogenesis, we don't know much about the lymphomagenesis for DLBC lymphomas and rheumatoid factor negative multiple lymphomas. Thank you.
Thank you for this very nice discussion. I hand over now the chair to my colleague.
Thank you, Hendrika, and thank you for the two speakers for adjusting to the time. Well, we now move to our second case, the co-occurrence of anti-synthetase syndrome and Sjogren's disease, a truly challenging diagnostic and therapeutic overlap. To present this case, please welcome Dr. Onorina Berardicurti. She's a specialist in rheumatology and clinical immunology at the Fondazione Policlinico Universitario Campus Biomedico de Roma, and where she leads the dedicated Sjogren's unit. She's also an associate professor of rheumatology at Link Campus University of Rome and member of the Sjogren's Disease Steering Committee of the Italian Society of Rheumatology. Whenever you want. Thank you.
Okay. Good morning, everybody. Thanks for the nice presentations. And thank you for the opportunity to discuss and to present this case. So, patients with the co-occurrence of anti-synthetase syndrome and Sjogren's disease. You are allowed to take videos and pictures during my presentation, and these are my disclosure. This case is important because it gives us the opportunity to discuss together about a patient which was initially referred to our Sjogren's syndrome unit because of a suspected Sjogren's disease, but actually we have to rethink about her diagnosis and how our strategy treatment during her history, and also because it gives us the opportunity to discuss about the role of anti-Rho52 antibody positivity in patients with different autoimmune disease, but with the presence of a lung dominant phenotype. The journey of our patient started in January 2023, and unfortunately, it ended in the late July 2023 of the same year. She, yes, because she was a female, was a 68-year-old Caucasian female, and she was admitted not to our unit, but actually to our hospital in the emergency department because of persistent fever, Zika symptoms, especially xerostomia, progressive dyspnea, and myalgia. She had this condition from several months, and she was treated by her physician with antibiotics, but without any results. At the physical examination, she presented bilateral fine expiratory crackles, but we didn't find any muscle weakness, any skin rashes, no arthritis, no lymphadenopathy, no renal phenomena, or ulcers, serositis, and so on. Actually, her medical history was unremarkable. In fact, she reported only the presence of Hashimoto thyroiditis, and she was taking medication only for this condition. She had no smoking history, no relevant occupational or environmental exposures, and no contact with at-risk animal. We performed a high-resolution CT scan of the lung, and we found the presence of an interstitial lung involvement, characterized both by the presence of fibrotic and inflammatory markers. In fact, we had the thickening of inter- and intralobular septa, both centrally and peripherally in the lungs, associated with the presence of multiple areas of increased density with a ground glass appearance. All the infectious causes were excluded, so at the time the colleagues thought about an autoimmune disease behind this presentation, and they performed an immunological assessment. So the positive was positive for anti-nuclear antibody with a Golgi pattern, and she had the presence of anti-Rho52 antibodies, only the anti-Rho52, not anti-Rho60 or the anti-SSB antibodies. She had also an increase in the inflammatory markers, but the muscular enzymes were within the ranges, and at the pulmonary function test, she presented with preserved volumes and only a moderately reduced DLCO. She was treated with antibiotics, both associated with corticosteroids steroids, she improved, so she was dismissed, and actually she was referred to our unit in the outpatients clinic in April 2023. At the time, at our first evaluation, she was stable compared to her dismission, so we performed a minor salivary gland biopsy, which actually confirmed the diagnosis. But in the meantime, she had a rapid deterioration. In fact, she was admitted this time to our inpatients clinic because of the insurgence of acute respiratory failure. In fact, she at the blood arterial analysis presented severe hypoxemia on high flow nasal cannula, and we performed a new scansion, new imaging of the lungs, which demonstrated the presence of a progression and acute expansion of the damage in the lung, especially the expansions of the ground glass opacities. So we excluded this time all these possible infectious causes and also neoplastic causes, and we performed a bronchoalveolar lavage, which showed the presence of an increase in the CD4-CD8 ratio and the presence of neutrophilic inflammation. So it was clear at that time that we were facing a rapidly progressive ILD condition in an autoimmune disease, but with this data, we were not so sure that the only presence of the Sjögren disease actually could explain this kind of manifestation of our patients. So we rethought about her diagnosis, and we performed again our immunological markers, and this time the patients came out positive for the anti-PL7 antibodies. So we made a diagnosis of an overlap syndrome between the antisynthetase syndrome and the Sjögren disease, and we promptly started the treatment due to the rapid alteration in her lung function, and we started with actually different drugs, so with an important immunosuppressive strategy. So we started with methylprednisolone pulses, followed by active tapering, and also we added mycophenolate mofetil up to 3 grams a day, intravenous immunoglobulins to have something that started very fast to treat the ILD condition, and also we added the nintedanib. The nintedanib was later discontinued due to severe diarrhea, but following the treatment, the patient started to improve, and she was discharged in June 2023 with a minimum requirement of oxygen and actually a good lung function. In fact, her pulmonary function tests were comparable with those we performed in January 2023. But after shortly, she came back to our unit because of septic complication, maybe due to the aggressive immunosuppressive regime used in these patients. In fact, she developed a septic shock and several opportunistic infections. So we stopped the treatment and we treated with this condition with the recovery of the patients. But when we tried to reintroduce the mycophenolate mofetil, she had several pneumonia infection, and she died in the late July following one of these infections and the complications of these infections. So in our opinion, this case gives us at least 3 learning points that we will further discuss, and we will discuss in depth in the next presentation with Professor Giacomelli. And the first one is Sjögren disease and antisynthetase syndrome may present as an overlap phenotype with ILD as a prominent clinical manifestations. The anti-Ro52 positivity may support a shared autoimmune profile and help identify patients with overlap features, but we think more about the anti-Ro52. So the presence of these antibodies in different autoimmune conditions with the same clinical manifestation may underlie shared alteration in autoimmune pathways and could help us in identify this possibility in different patients. And the early recognition of rapid progressive ILD is essential, but treatment requires a careful balance between immunosuppressive efficacy and infectious risk. And now I want to thank you for your attention.
Thank you, Honorina, for that compelling case. For the discussion, I'm honored to introduce Professor Roberto Giacomelli. He's a full professor of rheumatology and director of the Rheumatology and Immunology Unit at the University of Rome, Campus Biomedico, a highly experienced clinician scientist with decades of contributions across systemic autoimmune diseases, with broad expertise spanning Sjogren's disease, systemic sclerosis, and targeted biological therapies. He's also a member of the scientific committee of this institution, the EULAR. Professor Giacomelli, the floor is yours.
Thank you very much for your kind introduction, and thank you for all the people attending the meeting. And this is a session devoted to difficult to manage case in Sjögren. As you saw before, we spoke about multiple lymphoma and lymphoma in general, and interstitial lung disease that is a very great problem for many patients. The pictures and videos are allowed, and they are my disclosure of interest. So, lung involvement in Sjögren disease is a practical issue, and the pooled prevalence of ILD in these patients is about 23%. And but we have a marked heterogeneity across different studies and different cohorts. We have also to tell that in general the diagnosis is increasing in the last years, probably because the improvement of the methods for searching for interstitial lung disease, especially the high-resolution CT scan, that is increasing the number of patients that are diagnosed with interstitial lung disease. Sometimes the ILD may precede the Zika symptoms, and this is a problem because sometimes they are referred as idiopathic pulmonary fibrosis. And the positivity for Ro52 generally refer these patients to our institution, and we have to tell that in the last years the lung involvement is frequently diagnosed together with diagnosis of the connective tissue disease. There are some important points. Sorry. There are some important points that we have to remember. There are some risk factors associated with the development of ILD, the older age for sure, the gender, male are more affected than women, smoking history, low DLCO, cough, dry cough is very important, dyspnea, and of course the positivity for Ro52. autoantibodies. About the radiologic pattern of the ILD, generally non-specific interstitial pneumonia is the more common pattern that we may observe in these patients. But in the last years, also the usual interstitial pneumonia pattern is increasing, and now they are nearly as common as NSIP in our patients. And of course, this pattern generally show a more aggressive disease. In the past, we supposed that lymphocytic interstitial pneumonia was the pattern more common associated with Sjogren disease, but in the last years, this opinion is changing. And the uncommon presentation in the radiologic pattern is the organizing pneumonia. This is uncommon, but is probably the condition showing the best outcome because it's rapidly sensitive to corticosteroids treatment. After the case that Dr. Berardi Curti showed you, we were aimed to search in literature how many other patients with this specific overlapping disease were already published in literature. And we found 7 other 6 cases, together with our case, were 7 cases published in literature. And the phenotype of the patients was generally different, and also the autoantibodies associated with antisynthetase syndrome were different. Some patients showed JO1 positivity, some patients showed OJ positivity, some patients showed PL7, as in our case, positivity. And also the ILD presentation was different, modifying from NSIP to WIP, mainly in SIP. What makes the difference was the outcome, because generally the other 6 reported cases had a favorable outcome, and only our case died after 3 months of treatment. So we decided to search in Italian community. We have a register of patients with Sjogren syndrome in the Greece, the Italian group studying Sjogren disease, to retrospective search how many patients may be classified in both the disease. And we analyze, of course, our database, and we found that we found 17 patients in our database that meet both the classification for Sjogren disease and antisynthetase syndrome. And all the patients displayed anti-Rho positivity. 88% only the isolated Rho52 positivity, and also PL7 and PL12 were very well represented. Among these patients with the double diagnosis, 82% had interstitial lung disease, confirming the importance of the lung involvement in this specific atypical subset of patients. And here you can see some of the demographic data of these patients. They were all female, and Rho positivity was the most of the patients showed the Rho positivity, and concerning the Rs at antibodies, PL7 was the most representative autoantibodies in our Italian cohort, and they were treated with a different kind of immunosuppressants for their disease. The clinical features of these patients are very important because we observed that the interstitial lung disease history was already present at the onset of the disease in 14 patients. The HRCT patterns was largely unsip, and only a small part of patients the usual interstitial pneumonia. The predominant ILD involvement was fibrotic and not cellular. And what we observed at the onset of the ILD diagnosis was a significant reduction of the LCO that should be considered a very important biomarker, clinical biomarkers in this subset of patients. What these two diseases share together is the positivity for Rho52. So we have to try to understand what could be the role of Rho52 in this subset of patients. Rho52 is also named TRIM21 and is a very important immunological molecule because it is an ubiquitin ligase that is able to act in the complex mechanism related to the interferon pathways. After interferon stimulation, the type 1 interferon receptor, the pathway of the receptor is able by GGAS activation to induce several immune-related factors, interferon-related factors in the nuclei of the cells, thus increasing the interferon activity and the interferon production of the cells. But at the same time, a control mechanism is activated, and part of this control mechanism is due to the expression of TRIM21. TRIM21 is able to interfere with the interferon-related factors 3 or 7, thus decreasing the activity of interferon, and move to the surface of the cells, try to stop the link between the interferons and its own specific receptors. So TRIM21 acts like a down regulation mechanism of interferon activity. And we may speculate that the presence of specific autoantibodies against TRIM21 enable these control mechanisms, leaving the interferon pathway able to act and to sustain the chronic inflammation and the activation of these cells that probably may lead to many clinical manifestations of the disease, and especially in the lung. What is not clear, probably we need also to find a cofactor, because not all the patients with Sjogren disease and Rho52 positivity develop interstitial lung disease. That is much more frequent in the patients with antisynthesis syndrome. So probably there is also a cofactor that we still don't know that is able to increase the effect of this the effect, the inhibition of TRIM21 thus leading to the lung involvement in these patients. We decided to try to define, is the experience of the Italian group, what is a possible risk stratification for this subset of patients. And we observed that the baseline involvement, clinical involvement of the lung is a very strong predictor of poor prognosis, especially in the overlap syndrome. Also, the age is a strong risk factor for bad outcome in these patients. Probably age is also related to the possible comorbidities that we may have in this subset of patients. Our patients was very old. Also, the usual interstitial pneumonia pattern at the CT scan is a strong predictor of bad outcome. And the autoantibody specificity as anti-Rho52 positivity is a strong predictor of bad outcome, especially in patients with associated antisynthetase syndrome. How we treat the interstitial lung disease in Sjogren disease. Generally, we divide our therapeutic strategies in two steps. The first step is the first line approach using high levels of glucocorticoids and associated with steroid sparing agent, more frequent now the mycophenolate, which is largely and widely used in these patients. But sometimes patients develop a progressive form of the interstitial lung disease, and so in this case, we start therapy with cyclophosphamide pulses and associated with rituximab, especially in patients in which we have also some clinical features like cryovasculitis that are a clear marker of B-cell activation. As far as the antisynthesis interstitial lung disease management is concerned, has been recently published a guidelines. Of course, guidelines try to transfer the complexity of the disease in the accountability and the possibility to treat our patients, which we know are generally different from each other. Anyway, the suggestion is that when we have an interstitial lung disease associated to inflammatory myositis, we have to start an immunosuppressive treatment, including glucocorticoids, calcineurin inhibitors, and rituximab, more than mycophenolate. If the patient is at high risk, the combination therapy should include also cyclophosphamide, rituximab, and when the form seems to be progressive, and it's a very important point, the definition of progression in the interstitial lung disease, to add an antifibrotic treatment like nintedanib. If the treatment reach the goals, we may continues the treatment, the oral treatment for these patients. Otherwise, if the progression of interstitial lung disease is going on, we may consider also some other alternative therapies, such as JAK inhibitors associated with cyclophosphamide, intravenous immunoglobulin, and also sometimes to consider the immunological therapy like a bridge to the lung transplant that sometimes is the last possibility for these patients. In this case, I think that we have to speculate and to propose a hybrid approach for these very complicated patients, including some suggestion for the treatment of interstitial lung disease in Sjögren and in antisynthetase syndrome. So we discussed and proposed to start immediately in this kind of patients glucocorticoids pulse and an early rituximab intervention due to the data showing the good efficacy of rituximab in the lung involvement both in Sjögren that in patients patients with disease associated with ARS autoantibodies. And after this induction treatment, to move to the maintenance treatment, considering as an issue the safety of the patients, and so continues the treatment with classic oral immunosuppressants and add immediately antifibrotic treatment when we have the markers of a fibrotic progression of the lung involvement. But coming back to our patients, infection is a real burden for the mortality of the patients. The intensive therapy, the intensive immunological therapy for the treatment creates, of course, a significant infectious risk for these patients. And we analyze in our cohort the risk of infections, and we observe that the loads of steroids, the severe lymphopenia that may be induced by the treatment, and the pre-existing lung damages are safety drivers in this kind of patients. Also, the high hospitalization rate for these patients, exposing them to different kind of nosocomial infection is a very important point to consider. And in any case, in all these patients that we treat in this condition, is mandatory the right prophylaxis for the classical opportunistic infections, and also to extend the vaccination in these patients. So in the conclusion, the take-home message is that there is probably a unique spectrum of the disease marked by the positivity for Rho52 patients with a classic severe pulmonary phenotype. We have to choose an integrated care for these patients due to the severity of the disease, and also to find a balance between the aggressivity of our treatment and the safety and the infectious risk of these patients. And let me thank you, all of you, for your attention, and the group in my university working in the Sjögren unit, and all the group that are in the rheumatologic unit that I lead. Thank you very much for your attention again.
Thank you very much for this nice presentation. And I would ask the speakers to come on the stage so that we can have a good discussion. Maybe the seniors on the right and the more juniors on the left. Thank you very much. Now the session is open for discussion. So are there questions? Athanasios Tsoupas.
Thank you. I enjoyed both presentations. Congratulations to the speakers, all speakers. Fortunately, patients with Sjögren's syndrome live more and they do not die as these two cases. No questions, just 1 minute comments. The first comment is that in the question, do we have predictive markers for lymphoma in Sjögren's? The answer is yes and no. We have excellent predictive markers for multiple lymphoma, not for deep LBCL lymphomas, because we do not have large numbers of these patients. And for the audience, please give a really care on the unmet needs as discussed by Andreas. There are really important unmet needs to understand the transition period from multiple lymphoma to bad lymphomas. We do not have, at that time, we do not have biomarkers. For the second case, just one comment. Sjögren's do not die from interstitial lung disease. They die from other persons, from other reasons. They do not die. They die from lymphoma, etc. Interstitial lung disease in the primary form of Sjögren's is actually the extension of peribronchial infiltrates into the interstitium that gives us a picture very similar to fibrosing ILD and impaired DLCO. That does not mean fibrosing alveolitis leading to death. And the second comment, if you have a patient, in my practice seeing more than 1,500 patients with Sjögren's syndrome, if you have a Sjögren's syndrome with an overlapping disease, the clinical picture of the overlapping disease predominates ever. If you have patient with rheumatoid arthritis, signs and symptoms of rheumatoid arthritis prevails. If you have a patient with Sjögren's syndrome and lupus, lupus signs prevails. If you have a patient with anti-synthetase syndrome, the anti-synthetase syndrome signs prevail, as in the case of Roberto. When, if you remember, in the second slide from Honorina, the patient had fever. Patients with primary disease never have fever. If you have fever in Sjögren's, think infection, think something else, like in your case. I enjoyed your cases. Thank you very much.
Thank you very much. I would ask to comment the two speakers on this comment from Athanasios, or you start? Yes, the press.
We start with the first case, maybe? First case?
Thank you, Athanasios, for your comment. I agree with you that the patients with Sjögren's syndrome generally do not die for lung involvement. And from a pathophysiological point of view, I also agree that the epithelial inflammation of the bronchial area, airways and probably deep lung following the pathogenesis of the glandular involvement may be the driver for the lung involvement in that patients. agree also that the disease, the Sjogren is the weakest autoimmune disease probably, because anyway, anytime we found an association, an overlapping syndrome, the other syndrome is stronger. But independent of the pathologic mechanism, improving the techniques for diagnosis, we see that is increasing the lung involvement in our patients. As I tried to tell before, it's very important the definition of progression, because we have to treat only progressive, fibrotic progressive patients. Otherwise, it's better don't do anything. Agree with you.
Thank you very much. Andreas?
Yes, thank you, Professor Zoufas, for your comment. Yes, actually, we do not have predictors for DLBC lymphomas, the most aggressive form. It's very instructive to study in terms of pathogenesis the transition, how multiple lymphomas switch to DLBC lymphomas, which are more aggressive. Anyway, Sjogren disease is a human model for lymphomagenesis. So this is, again, one strong point of the disease in terms of pathogenesis. Most likely, the regional lymph nodes play an important role in this process, and not only the salivary glands. We miss these events because for research purposes, it's unethical to excise regional lymph nodes, but it would be very, very interesting to see the events at this level, because DLBC lymphomas usually developed in the regional lymph nodes. We have still much to learn in terms of lymphomagenesis and in clinical practice, but the important thing is to diagnose as early as possible, not only DLBC lymphomas, but also multiple lymphomas.
Thank you. Another question? Name and...
Good morning. First of all, congratulations for excellent presentations and very interesting clinical cases. My question is about lymphoma. It is that may imaging in some way predicting or identify lymphomagenesis in parotid or PET scan. Would it be an interesting monitoring for lymphoma using imaging and the intensity of metabolism?
Do you want to answer the question?
Lucas,
you can answer
the question. The red
Press the
button? Yeah.
That's an excellent question indeed. And I think the answer is yes. And there's been in the literature work done in this space. And we know that the high SUV intensity in PET really can show this transformation to MALT and probably from MALT to DLBCL. So I think there is space for advanced imaging, I mean PET-CT, not that much CT scans, but PET-CT, and we have some thresholds on the SUV. We need more validation to see what is the appropriate level. Instead of doing biopsies again and again and again, we had, I think, 5, 6 biopsies in the patient we presented. We can do an imaging scan and be much more targeted regarding the tissue that we will biopsy and the results.
Yes. For DLBC lymphomas, this is the case, but for multiple lymphomas, we cannot rely on PET-CT. You need a biopsy. And even if you have the clinical impression and the imaging findings supporting the diagnosis of DLBC lymphoma, you still need the biopsy to give therapy, okay? So as Lucas said, PET-CT is useful for monitoring for DLBC lymphomas, but this is not the case for multiple lymphomas, which evolve slowly and they're more indolent
May I ask, so you are speaking most about lip biopsies? I'm here, Andreas, about lip biopsies, and most of the mild lymphomas are located in the parotid gland. And
Yes,
ultrasound could be a screening tool.
Yeah, there is a concordance between lip biopsy and parotid biopsy at some extent. You should go where the money is. If you have parotid swelling, you should do the biopsy in the parotids. Usually, we do biopsy in both sides, in the parotids and lip biopsy as a pair. But don't forget that the disease is patchy. Okay, you may lose the diagnosis, especially in mild lymphomas.
Thank you. However, lymphoma may represent syndrome, Sjogren's syndrome activity, and if PET scan shows high intensity, even we don't know if it is mild or it is diffuse Wark cell. Maybe if we know there is Sjogren's syndrome activity in large scale, may we use rituximab, even we don't know if there is MALT, in order to control the disease and kind of prevent or already treating multiple lymphoma?
Okay, short answer, please.
The treatment for multiple lymphomas and DLBC lymphomas are different. If you have a DLBC, you need to administer R-CHOP. That's for sure. Now, to use rituximab in cases you cannot discriminate what is going on, you need the biopsy. You need to do the biopsy and clear out the situation. Otherwise, you decide to give a therapy, but you don't know what you're treating. Okay, for high-risk patients, as we discussed, we don't know if an early intervention would benefit and stop the progression towards multiple lymphoma. But if you have signs of diffuse large B-cell lymphoma, you need the biopsy and start treatment immediately.
Thank you. We go on to the next. Thank you. Short question, please, and short answers if possible.
Thanks a lot.
Maybe
Gavagna from Italy. My compliments, first of all, to everyone, and I think that Roberto touched the target, because TRIM21 and anti-Rho52 antibodies are key cornerstone for the diagnosis of antisynthetase syndrome. They are included in the new classification criteria of antisynthetase syndrome that will be presented tomorrow, but they are also important in other cognitive tissue diseases, for example, in anti-MDF5 syndrome. You know that the positivity for anti-Rho52 is associated with an increased rate of rapidly progressive interstitial lung disease, but this is not a mere biomarker. This is the key point for the pathogenesis of the disease, because by increasing interferon signature, by increasing the action of anti-MDF5 antibodies, this will be very, very important.
Okay, thank you.
One suggestion.
Sorry, I have to interrupt.
Follow this suggestion. Honorina, please take note, because maybe that we could study lip biopsy in our patient with antisynthetase. Maybe that we could find something.
Sorry, we interrupt you. Maybe you can comment, Professor Chiaramelli.
Lorenzo, I agree with you, and I try to suggest this point during my presentation. About the biopsy is not easy, you know.
Yes.
We discussed a lot in Italy about this point, and probably just we should think to copy what the lupus studies are doing, and to imagine a liquid lung biopsy that could be probably less invasive and give us a lot of information. But I agree with you, Rho52 is also more a pathologic point than a diagnostic point.
I fully agree with you as usual.
Okay, I'm sorry. We don't have time for another question. So, on behalf of Professor Bootsman and myself, I would like to sincerely thank our 4 speakers. Okay, and all of you for your attention and engagement today. This session has shown once more why Sjogren's disease deserves to be at the center of our clinical and research agenda. Please keep on enjoying EULAR 2026. Have a great day.